Welcome to the Physio Insights podcast, presented by Run Easy. I'll be your host, Dr. Jimmy Picard. I'm a physical therapist, running coach, and team member here at Run Easy. On this show, we have real conversations with leading experts, digging into how we recover from injuries, train smarter, and use data to better guide care. Whether you're a clinician, coach, or an athlete, we're here to explore what really matters in rehab and performance. Let's dive in. Luke Nelson, welcome to the Physio Insights podcast. How's your day going?
Jimmy, thank you very much for having me. It's been a good day. I'm at the opposite end of the day here over in Australia. So your day's just beginning. My day's is winding down. So I can tell you it's a good day ahead. I'm speaking from the future. So it's been a busy day in practice today. Treating lots of different things. I love doing what I'm doing. So thankfully still got the energy to talk with you and talk about one of my favorite subjects as well too. So thanks for having me.
Awesome. Yeah, no, thank you. For coming on after a full work day. I can see back there the windows. It's dark outside. My window, the sun is just starting to rise. So speaking from the future. Well, for the listeners, Luke, who don't know you, give us a quick introduction.
Yep, excellent. I'm a sports and exercise chiropractor based here in Melbourne in Australia. So that's sort of down the southeast. Beautiful spot to be. Sporting capital of Australia, we call it down through here. A lot of runners, lots of different sports actually. But yeah, sports and exercise chiropractor. Also done a lot of postgraduate study in that time. So I've done a master's in sports science and also then added strength and conditioning coach and also as a running coach as well, which is something I've done more and more of over the years. So been in private practice for close to, this will be 23 years now, this 22 years. Really enjoy it. Love the people that I work with. Over the time I've found myself progressively working more and more with runners. Something I changed clinics, sold out of my previous practice, would have been close to 6-7 years ago now, and had a really hard think about who I enjoyed working with at that time and realised that I love working with runners. And so that's sort of when I moved to this location that I'm in at the moment. I set about my way to get as many runners as I can in through the door and surround myself. And so we talk about running all day.
Love it. Where did the passion for treating runners come from?
Probably out of my own enjoyment, I think. I sort of found myself, like, as I grew up, I was always a pretty active kid. I played a lot of different sports when I was younger, mainly a lot of basketball, actually, despite my height, but played a lot of different sports when I was younger. Never really excelled at any one thing, but I sort of, as I got into clinic life, actually, I realised that, trying to play social basketball at 9 o'clock on a night and getting home at sort of 10:30, 11 and getting up the next morning didn't really work so well with the routine. So that's where running, I sort of got drawn into that and just gradually did more and more of it and ran my first marathon, swore I'd never do another one at the finish line after that. But here I am now, sort of 12 marathons later, I'm still going. So yeah, I sort of, out of my own passion for running, then realised that that's who I wanted to work with. I think one of the things I like about working with runners and even with active people in general really is that their pursuit to want to better themselves. So, there's always that, I'm trying to get, not necessarily be the best in the world, but I'm trying to be better than I was yesterday. And so that's, the process of training and, striving for PBs. And so I really like that. And I like to sort of be involved with those people and not just getting them, pain-free, but also then helping them to achieve those goals and to excel. And I think that's where I sort of started to fall more and more into coaching over the years and getting drawn into that area with my strength coaching and also with my run coaching as well, was taking them from, pain to essentially to performance and getting them to taking them beyond the treatment room.
Yeah. So when did you start leaning more into the coaching side?
It sort of just happened, gradually over time. Like it sort of, years, I wouldn't say there's a day where I said, I'm now a coach. I mean, I had certification, but in terms of actually coaching runners, I was doing that well before I got my official certification. And it sort of came out of a need where, you're seeing runners and, we're treating them, managing them for an injury. And then they're like, all right, what do I do next? It's like, well,
yeah.
Do you have a coach? No, most runners don't have a coach. And even back then, this is well before the AI programs, and we could talk about AI programs, or bad mouth the pros and cons of them another time. But most runners don't have a coach. And so they get to the end of that rehab journey and they need some guidance on where to go. And so that's where I sort of then became more invested into that and saying, all right, well, we're at this now. We can run for 30 minutes. You've got this race in 6 months' time or 2 weeks' time. And so this is what we're going to do around that. So, and found myself really, really enjoying that. So then I just started taking on more and more and more, until I'm at the point now. And I've got a great sort of diverse group of runners that I work with. I've got some very fast runners. I've got some runners that will, walk, jog. I've got a wide variety of ages. So it's just really, really cool to be a part of their journey and for trusting me to help to take them along.
Yeah, no, I love it. I think it puts you in a unique situation where you're able to, like you said, help them all the way through the spectrum from being injured to crossing the finish line. I think a lot of runners, so I have a similar kind of business model as well. And I feel like I hear a lot of people coming into me and like, that's the reason why they picked working with me for PT, was because they knew that I could help them get all the way.
Yeah.
So I'm sure it's pretty similar for you out there.
Absolutely. I do joke and sort of say, my job is obviously to get them well, to get them out there. But then as a coach, then I break them again and then they come back in to see me. So, you could get a nice little business model going there. That's exactly right. My runners haven't caught on to that just yet. But no, I'm joking for all my runners that might be listening out there. I'm joking. But it does work well to take them on that whole journey. And that's what I sort of really, I guess got a bit sick of treating pain. It's moving beyond that pain model, I think, was really what excited me about getting people to perform at their best.
Yeah, it's fun. It's like, it's a different skill set. It's still a lot of the same skills you use probably as a clinician with your reasoning, your communication with patients, but it takes away the pain is tricky and it gets tough when you're just seeing pain all day long and trying to help people get out of it.
Absolutely. And I think, look, it's good, again, as a coach, having my clinician hat on as well too, because, inevitably as running, the rates of injury in running are so high that runners will develop, some sort of ache or pain. And then as a coach, I'm able to sort of say, all right, these are the things we're going to tweak in your running programming, or these are the things we're going to add in from a strength point of view. And so, we know that load management is so important from a sporting injury point of view, that it just sort of, again, makes sense to have that coaching hat to be able to pull those levers.
Yeah. And then if we flip that, how does the opposite help? Like, how does coaching help your rehab process?
Yeah, a lot, because again, it's sort of, having understanding of structure and having a framework and being able to know at which times we do things, where we should be, how we can modify, how big a jump we can make, how much we can cut back to then move forward. So it's a really, that's why I think that clinicians can make really good coaches, because they've got that, that understanding of anatomy and injury and load management that is really crucial to being a coach.
Yeah, no, I love it. I think more PTs, chiros, sports folks should cross into this world. I think there's people are sometimes a little apprehensive or afraid to coach more, but I've had a blast doing it. Sounds like you have as well.
Yeah, no, I love it.
Awesome. Well, Luke, I've been following your stuff for a long time, and recently, I think it was like a month ago, I reached out because you released this calf rehab protocol that you put out. Let's get into that. I'd love to hear first, just what made you put that out?
Just again, and I guess it comes down to a lot of the stuff that I've done on socials over the years and creating content. When I moved here, again, it was all right, I'm going to start to get a bit more involved in socials. And I really enjoyed putting the content together, because it allowed me to put my thoughts on paper and sort of, again, just sort of, clarify kind of in my own head as well too, my approach to doing things. And that in a way has also refined what I've done, because sometimes I'll do these things and I'm like, I think I could do that a bit better, or, this is, and again, when I'm doing content for social media and delving into topics and looking into research, it's like, okay, yeah, that's not technically correct, or I could do things a little bit better. So it's sort of come from a point of reflection, but certainly calf injuries is one that I see a lot of in distance runners, and for those that work with them, we'll certainly see a lot of them as well. And so it probably came just from out of a necessity and also to provide that, because I also think that it can be a bit of an enigma for some clinicians, is that they're not quite sure what to do. Sometimes there's not much pain, it can be a bit confusing sometimes as what might be going on there. And then there's also just a lot of ambiguity about how to move someone through rehab and get them back to running. So that's where sort of I've put this out there as, one, to put my thoughts to paper and to help clinicians out there to guide them through a bit.
In the clinic, did you find that treating calves was tricky for you and that helped you kind of work through the thought process there? Yeah, tell me about that.
It certainly was initially. I've been in practice for 20 something years. I've made a lot of mistakes. A lot of misdiagnosis in that time, a lot of, it's a matter of getting those reps in. And unfortunately for those patients in the past that, there was some bad reps, things that I missed, and that then motivated me to learn more about, areas that I was deficient in learning in. Like we didn't do, a lot of the rehab, like we learned nothing about coaching back at uni, and nor should I expect us to, but even in terms of strength stuff, like we did learn some rehab, but I really identified that as being a weakness of mine when I graduated, and so I invested a lot of time into putting into that. And so when it came to calves, it was certainly a necessity when you're dealing with runners, because you're going to see calf injuries, especially if you're working with masters runnings with the old man calf.
Mm-hmm.
And it's just such an important muscle for just athletic function, even outside of running, other sports like soccer and, football, field sports, it's court sports. It's just such an important muscle group that, I guess my appreciation and love grew from the demand of, I need to know a bit more about this muscle group here. And when I went through uni, we were taught that this is showing my age here, but we were taught that the soleus was just a postural muscle, that when you stand there, it's just to stop you from falling flat on your face. And now we know that it's a heck of a lot more than that. And that's sort of, what a couple of decades of knowledge translation has done.
One of the reasons I was really interested in your framework and what you put out here is this is now 2008. I was training for Boston Marathon, and this was like a major injury. I strained my calf very bad. This is before I was a PT, before PT school. I was fresh out of college, and I went to a PT in my area. Again, this was a long time ago, but he diagnosed me with a lumbar radiculopathy and put me on traction.
Oops.
Yeah, that was the treatment protocol back then. And that calf injury, I would say, essentially ended my running career, competitive running career. And it was one of the most frustrating injuries I ever dealt with. Yep. And then the recurrence, it came back. I healed, got back to training, and then came back again. And eventually, I just switched. I started racing bikes for a time. Years went by and I ended up getting back into running, but it really just ended my competitive road racing career.
They can be really problematic. In number one, I mean, the diagnosis is usually straightforward. Lumbar radiculopathy is certainly a differential when you've got someone with calf pain. So that is something you want to tease out. But what you were saying about the recurrence is very true. And even in sport, a really good data set that's been gained over here in our Australian rules football, there's been a number of looking at the Brady Green, a researcher, has done some really good work in this area, but looking at the data set from AFL and looking at sort of recurrence of injuries, and they are still very recurrent. And this is in the AFL system, which is, they've got access to imaging, they've got access to, to rehab practitioners and physios and everyone else there, and they can still be recurrent. So if you're sort of not in that situation, then, it is, it's a real danger for re-injury, and, like what you experienced too. Just simply resting it. There's lots of mistakes that both runners and clinicians make when it comes to calf injuries, and one of them is doing nothing. So, and it sounds like what you had with lumbar traction is essentially, doing nothing. It's not doing anything to load that calf. So it's unfortunately for you, not unsurprisingly, that you went back and pop, there she goes again.
Yep. Yeah. Before we jump into kind of your 4 phases, why do you think these things seem to recur so frequently?
I think that there's a few things that go into that. So number one would be the actual demand on the tissue itself. So there is a very high demand placed on the calves, even from a slow running speed, even just when we're jogging, it's up to 6 times body weight going through that soleus there. So it's a huge amount of force. So it's very different to like a hamstring where, often after a hamstring, 48 hours later, you can get out and jog with a hamstring. With a calf, you just can't do that because the demands are just so high. So number one, the demands are really high. Number two, pain is often not a very good guide with these. They're often well clear of pain before there's been a full restoration of function. And especially when it comes to soleus, they can really hide. So clinically, we see those where even the actual incident itself, the runner will come in and say, did my run, felt fine, but then geez, afterwards it really stiffened up and oh gosh, it's so tight now. Like the next day I woke up out of bed and, really difficulty walking. There was no incidents. There was no bang, I've been shot, which, you get often with a hamstring. So there's that lack of awareness that's there. So that makes it really hard. And so from a runner's point of view and a clinician's point of view, they're sort of then thinking, oh, the pain's gone, I'm good to go. And back out there I go to run because the pain often goes, sometimes within 48 hours and sometimes even if they're just getting that soleus and it's just that stiffness, it can go within a few hours and then it returns. I had a case once where she was actually amazing. She was running on this, she was a trail runner and an ultra runner, and she was running on this decent medial soleus injury. She'd been running for 3 weeks with this thing and was still doing clocking up some decent mileage. And it was just sore. She's like, I just sore all the time. I'm taping it up. I'm taking anti-inflammatories. I'm doing all these things there. And yeah, so I was pretty amazed at what she was actually capable of doing and amazed that she didn't completely blow it to smithereens, but it wasn't getting any better because she just every day would just be going out there and splitting open that scar again. So I think that that's a couple of reasons there. The demand, the fact that pain is not really a good indication, that the rehab process is often not addressing, the function there. So we're sending them people out there that just aren't prepared. And there's also the other silly things that runners do as well too, in that, you might do all the best rehab in the world and then they're going out there and busting a round of, 400 meter reps on their first run back. So we've got to put some things down to stupidity as well. And then there's also, there's also structural changes that can occur. Like I know Carlos Pedret has done some good work around showing how there's changes in the architecture of the calf after one injury. And so that again, we're learning more about that and ways that we can rehab that to change the architecture of the calf. So it's becoming more complex and it's sort of interesting in seeing the research that's coming out on it.
Is that similar to what you see in the hamstring? I've seen a lot of some of Brian Heiderscheid's work where he would show even a year post hamstring strain, you're still seeing deficits on MRI in that muscle.
Exactly. Yeah, correct. Yeah. Just like that. So, changes in architecture, changes in fascicle length, pennation angle. So all these things there that may be permanent. So again, there's not the studies to show that can we actually influence that? And is this, are there reasons that we will predispose that person? So we better make sure that other stuff is okay because structurally they're always going to be more prone to that.
All right. So then as we dive in, first thing I want to ask is, who is this patient? Who's the runner that's typically presenting to you with a calf strain? Are they trail runners? Are they track runners? What is it? What does a typical calf strain patient look like?
Well, it doesn't discriminate, unfortunately. So, we could be slow jogging. And in fact, actually, that's how most of these. So when we're dealing with calf injuries in distance runners, that includes trail and ultra and road, it's the majority being soleus. So, roughly around probably 80% of the injuries, the calf injuries you're going to see are the soleus. And they're often injured at steady state running. So it's not like I've sprinted, I've taken off. Usually when we're seeing those injuries, usually that's more involving the gastrocs, those high muscles through there. But steady state running is very much more the soleus. So it doesn't discriminate between different disciplines through there. And it can even just be with slower running. One population, we've already touched on it before, one population that are more prone to this are the masters runners, and especially the male masters runners. And there's a few reasons why that might be the case. Number one is muscle decline as we get older, and the lack of strength, especially at the distal extremities. So we lose calf muscle much quicker and earlier than what we lose around through the quads and the hips through there. So we've got that age decline that we're fighting up against. And unless they run as a resistance training, then they'll be sliding off through there. So there's that. We're losing capacity.
Let me interrupt you real quick right there.
Yeah.
For all the listeners, Luke did a great podcast on his podcast, The Rehab Runway, where he talked about masters athletes, masters runners, and you addressed this kind of pretty thoroughly in that episode. Yeah. So check that episode out.
Thanks for the plug, Jimmy. You're right. Masters runners should be strength training. So that's one. And then we also do find then, changes in the Achilles tendon. So, the calf and the Achilles are the one structure. And when as we age, the Achilles tendon loses its ability to spring. So it becomes less stiff. So it becomes more compliant. And with that then places greater demand on the muscular unit. And that's why we often do see, I'm sure you've probably seen it as well, those with Achilles tendinopathy or with a history of Achilles tendinopathy are at a higher risk of sustaining a calf strain as well. So, yeah, it's certainly in terms of sexes, male is more common, but you do see a lot of women doing this, straining their calf as well.
Anecdotally, I don't think there's evidence on this, but do you see a difference in like morphology? Like, is it like these big beefy calves are protected versus you see the runners with the tiny little skinny calves? Those people, like, does that make a difference?
It's a good question, and I would say no. I'd say that, like, looking at that, I mean, running attracts, so that's one of the beauty of running. It does attract all shapes and sizes. And, you can see, I mean, traditionally, if you're looking at the elites at the, the top level there, and, some of these Kenyans, you look at how they're structured, they've often got very, very long, thin calves. There's not a lot of muscle bulk on that leg there. They've got quite long Achilles tendons, and that is super efficient for them. But then you see some runners that have just got, again, like milk jugs on their calf, and they can get going. It's more what I refer to as a yielding calf. Like, they're the ones that are more suited for things like rugby and when they've got to be really sort of pushing and straining into something. But that's the beauty of running. You see it in all shapes and sizes, and so because running attracts that, you see that happen in all shapes. And so no, I wouldn't say that there's one particular type of demographic. I don't know if you've seen anything, but I always do look, like, I like to look at calves. It sounds a bit weird, but looking at shapes of calves and looking for regions of atrophy and where things might be different from side to side, or even in component to component with the gastrocs and the soleus. That's one of the earlier things we do for a calf examination is looking.
Yeah. Now I bring it up because it's just like, clinically, I see patients who do strain them. Like you said, it happens in all shapes and sizes. But the ones that do have the beefier calves, the more well-developed calves, are sometimes frustrated because they assume that because they have big, bulky calves, that it's protective against getting a calf strain or something.
Yeah, and it sort of comes down to, we can talk about this whether now or later, but in terms of the different strength qualities and what the calf is actually needs to do, because the calf needs to be strong, maximal strength, because it needs to take those peak forces in running, like 6 to 8 times body weight there. So it needs to be very strong. It needs to do it very quickly, because the ground contact times in running are 0.25, 0.3 of a second. So it needs to be able to contract very, very quickly. And it also needs to be able to do that again and again and again and again and again, 1,000 times every kilometre there. So the calf, and then it needs endurance, it needs maximal strength, and it needs that reactive strength as well. So it needs to be able to do all these things. So a particular runner, and someone with those milk jugs on their legs, they might have very good maximal strength, but they have very poor reactive strength. And that's where our assessment can then dictate our rehab and where we might push that runner towards to work on their weaknesses.
Yeah, awesome. So during your assessment, when one of these runners walks into your door, where do you start?
So I guess it depends if they are we talking about an injured, so someone's just we are suspecting they've injured their calf. Okay. So first of all, I'm seeing if they can walk, because that sort of tells me again what sort of phase they're at and where we might start them with their rehab, because if they can't walk, they're on crutches and they're coming in here, I'm not going to be getting them doing jumping and hopping in our assessment, right? So the first thing is we're just, can they ambulate, and are they walking properly? Is there any pain associated with that? So observation there. Then, as I said, we are looking, we're looking at the calf and looking at that general shape, comparing from side to side. Again, looking for, you see some really interesting things in terms of atrophy. If someone's had, previous knee injury, they've had an ACL injury, and then that calf can also be quite atrophied as well. And if they're coming in with a left calf strain, you can guarantee that you're going to be testing the strength of that, and potentially up into the knee as well. So certainly looking at that, and then seeing, are there any obvious signs where sometimes you do see, especially in a gastrocs, you can actually have retraction and you can see
like a defect.
Defects, yeah, exactly right. You can see defects in the calf through there. So again, that's sort of giving me some ideas of what we might be testing and where we might be steering our rehab towards. So that's sort of, again, without even touching them, we've sort of just looked and seen what's going on through there. Sometimes before I go any further, I will palpate. So I'll have them prone and then we'll just gently feeling through there. I don't want to hammer into that and really poke and provoke things through there, but really sort of feeling around, comparing side to side, starting up in the gastrocs through there, going all the way up into in the soleus, going all the way up into the gastrocs there. Any areas that are sore, I'll usually just measure where that is. So, if it's like 3 centimeters of soreness and it's in the medial soleus and this sort of far from the Achilles insertion. So just sort of making a note of where that location is and the size of the palpatory soreness, because that can sometimes give, generally the bigger calf strains are more sore. And sometimes it doesn't reveal a lot. Like some of these low grade calf strains that can really hide. I've had those where you're just sort of feeling it's like nothing's really sore that I'm pressing on there, but everything's all sounding like it. So we're going to manage it this way. Or if you want to go to imaging to confirm that, that's another option too. But that's where we're looking at the sort of the palpation. Then we can just sort of gently test what it's like under stretch. So I'll have them, laying prone and just dorsiflexing the ankle there just to see how comfortable that is for them. Getting them pushing back into me. Then, bending the knee up a little bit, which takes a little bit of the gastrocs out. There's still gastrocs involvement there, but bending the knee up, doing the same thing again, testing that contraction. And if that's really sore and they can't push there, I'm not going to get them standing and doing things. But if they pass that, then I'll get them up and we'll start to do, all right, let's go into a double leg calf raise, looking at them doing that. How's that feel? No pain at all. Okay, let's go start to shift your weight over onto one side. Can you put your weight onto that single leg? Looking at height, looking at quality, obviously looking for pain production through there. No pain on that at all. Then I start to sort of go through a bit more into the stretch shortening cycle. So I might sort of do some pulsing on the spot where they're doing some faster calf raises on two legs. Then I'm going on to one leg. And if they're getting through that, then we can start in some very light jumps on the spot and then some very, very light hopping on the spot there. And the beauty with that too is it tells you, and obviously if pain, you stop right there. So if it's like, well, that's sore, well, you're not going to keep pushing them on towards that. But it can give you, what that gives you is a good idea of where you're going to start your rehab too, right? So if you're not like, well, I can double leg calf raise, but I can't single, guess where we're starting? We're starting at a double leg calf raise. So sort of just a really quick screening process we can get through there. The other thing I do, which actually preempts that, so once I've got them off the table, then I usually check like ankle range of movement. So I usually do like a weight bearing lunge test there. So, doing that with the knee bent. So with a typical like a knee to wall test. These days I'm tending to use the inclinometer on the phone more for that. So just to measure the angle there. And then we do it with the leg behind into an extended position. So that's where we're testing the range. So I'll go table or sort of observation, table, weight bearing lunge test, and then into those sort of, tolerance testing. And then depending on where we're sort of getting to, will then dictate whether we do strength testing. It's very unlikely if I've got someone with a calf strain and they've just done it, it's very unlikely that I'm going to get them doing any strength testing on that first session because it's fresh. I know what's going on. It's not really going to tell, like it could provoke them. And so we tend to leave that for, a little bit later. We gradually build them up to know that they're confident in doing that, in doing those tests without injury.
Yeah. And so that patient there that you're describing would start your at the first phase of your kind of protocol,
Correct.
which is called settle and load. Can you walk us through that?
So settle and load. So that's the first step there. So basically it is, just as the name suggests, it's settling it down. So it's stopping the angriness out of it. But at the same point, it's starting to introduce some early load, which is not going to be provocative. So if the main sort of, I guess, the key goal to this phase is walking. So, pain-free walking. And once we're through that, then we can start to pile and we move into our next step. And sometimes a patient comes into us and they're walking fine. A lot of the times they're able to walk fine. It's more the higher threshold stuff that they're feeling it on. So sometimes we actually almost skip that phase, but we can still use some of the exercises in there to sort of test them early on because they're easy to overdo. And the tricky thing sometimes with these is they might not give you messages at the time. It's the next day. It's like, well, I've overdone that and it's too late. So they don't warn you at the time. So that's where sort of, I guess, gradually sort of building things up. And that's where it's sort of hard from a clinician point of view. Like if I'm going to say, oh, Jimmy, I'm going to see you in 2 weeks. I don't know how quickly you're going to progress through those things. And unless you're telling the patient to, this is what you do, then you go to this step, then you go to this step, and you tell them what to do. These things can change and progress pretty quickly. So I'd certainly suggest, seeing them close together or otherwise getting them to drop you an email and say, this feels fine. All right, now we're going to go onto this next phase through here. So
what do you typically do?
It depends on, like, with their, again, sort of, I guess, my schedule and easiness to get into. Sometimes it's like, well, look, I can't see you before this date, so this is how we're going to do it. But generally, I'll say I'll definitely see if I'm seeing someone. Let's say it's a Monday, and I'm seeing someone with acute calf injury. I'll be definitely following up with them in person by the Friday. So that's at least 3 or 4, 5 days later. If circumstances are around, well, I've got, a race coming up. I'm running Boston in 4 weeks' time. I really need to turn this around pretty quickly. Well, then I might say, no, let's get you in on Wednesday, and let's get a look at this through here to see if we can move things along a little bit quicker, because for them every day matters. So again, different circumstances, it can depend. On their priorities, but generally, I would definitely not leave them, especially those early days. I would not leave it longer than even sort of 4 or 5 days, because things are going to be changing pretty quickly. So that's where I'll usually try and get them in that time.
Yep. And during this acute phase, I feel like often I just had an email from a patient actually this or end of last week where he strained his calf, right? Like I'm treating him for something else. He strained his calf. The gut reaction is just complete rest, right? He's like, I just want to like sit there. Like, why is that not the right thing to do?
I'm glad you raised that up, because that is a big mistake that we see. It's probably the number one mistake we see with calf injuries is doing nothing. And that's from a runner's point of view, obviously not from a health professional's point of view, but runners just don't do anything. They'll just, rest, you'll be fine. And that's why I term this phase settle and load, because we do want to introduce some early load through here and get them started on this process, because we know that when you injure a muscle, there's a number of things that happen around that. But number one is, there's physically tearing of fibers, and that requires, those to glue and stick together with a scar. And we know that if we can stress that scar early on, then the body is going to recognize, we need things to be pretty strong here. Whereas if we just rest that scar, let it lay down some scar tissue haphazardly, then, obviously not surprisingly, when we go back to load it again, pop, there it goes again. So it helps to ensure a better healing scar. It also helps from a neurological point of view, and that for that neuromuscular supply, because again, when we have an injury, the nerve supply to that muscle does start to reduce as well as a protective mechanism. So by introducing that early, just helps to keep that stimulation going. So we always want to be loading it. And usually I sort of say, like, we might say that first, if it's a decent size calf strain, we might say, well, look, let's leave it, let it settle for 24, 48 hours, and then we can start to move that. And that could be something as simple as doing active ankle and ankle dorsiflexion and plantar flexion, or doing some isometrics into a towel for those really high grade isometrics. And then for those lower grade strains, doing things like standing on a step isometric. So just holding position, whether that be double leg or single leg, if they can tolerate that, just holding for 20 or 30 seconds. So it's certainly a very low percentage RM, but it's just getting a little bit of stress into that tissue to help it heal along.
Love it. Early load, you're leaning into things like isometrics, walking, and then just monitoring symptoms. It sounds like you're looking at 24-hour response, not just like in the moment response.
Correct. Yeah. For those reasons I said before, unfortunately with them that they, and like a lot of us from other musculoskeletal conditions as well, isn't it really? Like it's not just the pain at the time, tendinopathies can behave that way as well too, or joint issues can do the same. It's like, it felt good until the next day and it really, really arced up. So we're definitely monitoring that response. And that's probably something I've changed a bit more of is playing a bit more focus on that than pain at the time. Like early calf rehab, like it's safe to have some low levels of pain, but it's more just how it behaves after that. Like if it really arcs up, if we've got a 2 or 3 whilst we're doing our rehab exercises, but then the next day that flares up to a 5 or 6 and I can't walk again, that's too much. So, and that's again where I've probably changed my approach over the years is allowing a little bit of discomfort when we're doing it, but not the following day. And as you said, those early loading exercises, the isometrics, the walking, the stair climbs, as well as another one that I'll use just to keep things ticking over.
Love it. And then during this phase 1, or there's a couple things like you're not listing in here, so like stretching.
Stretching, I don't tend to use so much, and it's probably just more a personal preference. It can be used. I mean, we know that stretching does provide stress on those tissues, and in theory, like you can get some strength from stretching. It just takes a lot of it to do it. So in theory, it could. I just haven't found the need, like the range of movement that is lost. So, when you're testing someone, you're more testing their stretch tolerance, like the body's stopping them from doing that. And that naturally comes off as you go through your rehab. It lets go and allows you to go into that range. So I've just probably found myself not out of need to do that.
I feel like a lot of times the patients present thinking that's the thing that they need to be doing. Are you trying to?
Yeah.
How do you talk to them about that?
Yeah, so I mean, it's also one of those symptoms that we do see in runners just generally, like that they stretch their calves. And because it's not because they're actually shortened and tight, it's because they lack the capacity there, and they're giving them these signals that make it feel stiff. So that's certainly a conversation I'm regularly having with runners about that sensation of calf stiffness. But the actual injury itself, because it's often new to them. So that unless they're having recurrent strains, they're not ingrained in a pattern of I must stretch this. Whereas things that are more chronic, like it's like I've got this chronic hip complaint, and so they're doing that. So I find I'm not having to correct them so much on that. Like I'll encourage them to give it the calf some TLC. So that can include, and I use my hands, don't hate me. I use manual therapy, but you can get a lot of pain relief in for these. They're coming in and they've got this spasm calf. They're so sore, get some manual therapy in there and then they can walk easier. So why wouldn't you use that? Right. So you can actually get them doing some light self-massage, and that might be around the areas around the injury itself. So foam roller, massage gun, and just getting them to do that lightly. So I'm more inclined to get them doing that than I am with stretching.
Personally, like when I had like a recurrent one, I had a clinician, this again, pre me being a PT, but a clinician that dry needled.
Yep, absolutely. I don't have my dry needling qualification, but I've got nothing against that. Like I work with, we've got a profession here in Australia called myotherapists. So they're like advanced trained massage therapists and they do dry needling. So yeah, I absolutely, I think that can work. I've just never done it because I've always had them to work with. So again, like working around that area, not necessarily needling through the scar, but around the area to help to relieve that spasm. I don't see there's being a problem with that at all.
Okay, more like supportive, not necessarily fixing the problem. Sounds
correct,
like
right? Because I mean, it doesn't restore strength, does it? Right. So we've got an injured tissue that has got and will have reduced capacity in that calf. So massage, self massage, and dry needling don't do anything to restore that strength. That's where we need the rehab, but it can form quite a good hand in hand partnership.
Great, awesome. So then, how do we know when a runner is ready to progress to phase 2, which is building strength?
So basically, again, they can walk, and when we're starting to, we can look at that range of movement as well as a test. So we can look at that and see that they're starting to let go there. They don't necessarily need full range of movement yet to pass out of this stage, but they can also start to load into the calf without any that single leg. We've had them doing some holds, some isometric holds on that side, and then we can start to progress them into loading things up. So yeah, looking at walking, looking at symptoms, and looking at that response to that early loading. So once they've gone through that, and again, so some runners might walk in the door and we don't even do phase 1. We just go straight into loading it up because they've got no symptoms outside of running and plyometric activities.
I'd like to take a moment to thank our sponsor, RunEasy. RunEasy is a running and jumping analysis tool that helps provide objective data on things like impact loading, dynamic stability, and symmetry. I've been using it in the clinic for the past 3 years, and I love how easy it is to add to my evaluations. Not only that, but it backs up my clinical reasoning and helps me with my decision-making process when I'm doing exercise prescription. So if you're a physical therapist or running coach, then book a demo. If you're lucky, it will be with me. All right, so as we get into phase 2, where do you see clinicians typically go wrong during this phase?
Not doing it. So just go straight to running. Yeah, you'll be right now. Okay, you're walking. All right. Now I think we'll go straight to running. So, but no, the honest truth is that it is often skipped. I think a couple of things wrong with that is, again, just not doing it in a step manner. And that's what I think, like learning in its simplest sense. Like I think strength and conditioning and rehab is just basically just turning the dial up on a target tissue. So doing something light and just keep doing harder things until you get to need to go to where you want for the task. So that's the sort of the approach I think we should be taking, is start light, and then, but as it's handled well, then load it up. And that's one of the things I think that runners and clinicians aren't very good at, is loading carbs. Like, I would have a discussion every day. Most of my new patients that I see, my runners, are not loading their carbs up heavy enough. I had one guy today actually, and he was doing double leg. He came in with, I was actually seeing now, I actually forget what he had. It was not calf related. It was shin. He had MTSS, so kind of, again, calf related, but he was doing double leg calf raises with 20 kilos on his back, right? Now, that's his body weight, well, essentially half his body weight, with 10 kilos added onto that. So we tested his calf strength. On a seated calf raise, he was actually pretty good. He was getting close to 150 times his body weight, which probably for a standing, he'd be able to get, if we did it as an isometric, he'd probably be able to get close to 2.5 his body weight. So that's his body weight plus an additional 1.5 times his body weight he's pushing up there. And he's
how are you measuring that?
On force plates. So I'm lucky that I've got access to force plate technology. So that is a part of my assessment for calves, and certainly not when they're in the acute stage. But as we start to roll out of that, that's when we start to put this sort of testing in there and see where they're at. But it was just so well underdone. And so the first thing is, I said, all right, well, firstly, we're going to switch to one leg. That's a start. That's at least putting, half your body weight on extra on there. And then we're going to put some more weight on that as well. I just don't think that because you don't get the feeling in the calves, right? You don't get that. You certainly can get that burn when you're doing it right, but runners just don't experience that. It's easy to get, maybe when your core or around your quads, if you're doing some lunges, I can really feel that. Whereas calves, you don't often. So you just do it and you think, oh yeah, I must be loading them up here.
Yeah.
But they're just so far off.
And with this example, this patient, it sounds like he was drastically underloading it. He thought he was loading it, but he was very, I had the same thing yesterday. I'm bringing up my notes from a patient yesterday. I saw who was MTSS as well. And I think he was using 25 pounds for his single leg heel raise. And this is a 200-pound man. So, so drastically underloading it. Yeah.
100%. And it's such a common issue. But again, from a clinician point of view, it's often, again, not prescribing heavy enough. It's like, oh, just do it with a dumbbell, a couple of pounds, 10-pound dumbbell, or not even that sometimes. It's like, just hold on to this and you'll be right to go. And so they're just well underloaded.
Yeah. In the rehab, in the protocol you have that everyone can download, there's an image of you, I believe, doing a single leg heel raise in a squat rack with a bunch of weight on your back. Is that right?
Yeah.
Is that your preferred method to load it?
It's one way. It's sort of, and this is where, again, getting this stuff done at home can be quite hard, right? Because you've got to, for me, I will do that I'm 70 kilos, and I'll do that with 90 kilos on my back. So I'm doing a body weight plus, 1.2, probably just over that of body weight on my back for reps. Who's got that lying around the house, right? Who can put another person? And I have had people do this where they've had their spouse jump on their back and they'll get away and do some calf raises. It can work. Not a bad idea. Yeah. Not a bad idea. It started actually during lockdown. We know we had a lot of restrictive lockdowns here in COVID, and we're like, don't have gyms. How are we going to get strong? It's like, well, let's try this, and have your kids on your back, and at least that's better than something. So it is actually really hard to load up sufficiently. And the other thing too is that runners don't really like that. They're often, lightly framed like myself. Having 90 kilos on your back, unless you've really trained in the gym, being able to sort of get tense and get under a bar and hold 90 kilos don't feel so good. So it's actually not my preferred way to do it. I like using calf raise machines. The calf raise machines there's no balance involved. Get under there, put the pins in there, load it up, and off you go. You don't have to worry about balancing. Yeah.
Is that something you have in your clinic, or you're telling them to go to the gym and find it?
No, it's not something I have in the clinic. I've only got free weights out in my gym space here. So it is getting in there. But it's actually amazing. A lot of my runners now have got gym access, or if not, they're looking for that final nudge to sort of say, yeah, I've been thinking about it, and now's a good time to do it.
Yeah.
So it is just very hard to replicate at home. Even doing isometrics, like a seated isometric, you can sort of set up at home in a way to do it, but a standing calf isometric is very hard to get under something and really drive up into it. So that's where the gym really comes in there to load things up.
And during this time, so as we're focusing on building strength, what's the set rep scheme you like to do? And then maybe parameters?
So usually like with the calf work, we might sort of start at, that's in that sort of 6 to 10 rep range. Sometimes we might push, the soleus a little bit higher, like it's got a few more slow twitch fibers. So sometimes it might respond to a bit more of a high rep range, but usually staying under the 10 rep range there to sort of focus on strength, on building maximal strength there. I think that, and in terms of prescription we're really building up to a point of having 2 reps in reserve. So getting that intensity right, so that you say to the runner, look, you should really only have 2 reps in the tank here. So by the time you're getting to the end, if you don't have 2 more reps, you can keep going, but ideally just putting more weight on for the next time. So yeah, generally working off that under 10, ideally around that 8 range. And then, usually 3 sets, and that might be done 2 or 3 times a week, just depending on how much we've got to really gain. So, if we've been able to assess this runner at this point and showing that their calf capacity is well below where it needs to, we might sort of say, let's try and get 3 sessions a week in to really get those numbers up as quickly as we can.
Is there a certain benchmark you're looking to hit with each patient?
So in terms of on our force plate testing, or on our
or just resistance? With load, either way, yeah.
Yeah. So with load, look, I think a good mark to go for there is if you're doing a single leg calf raise, you should be able to put body weight on your back and do that for reps. So do that for up to really 8 reps. So get 8, and I'm not so worried about height as well too. Like in terms of technique, it's more the depth. So I don't care if they can't get full height out of those weighted raises. I want full depth, and I want to just above parallel. So that does make it a little bit easier actually to load up even heavier.
So are you saying end range dorsiflexion you're trying to get to?
Yeah, exactly. So get to that dorsiflexion there. And there's been some studies to show, number one, that's better for the Achilles tendon, to improving that. And number two, it actually can get some greater hypertrophy gains in the calf by going into that lengthened position. So there isn't the requirement to go up into that full height. And that's where I think another reason is that, clinicians will often weight it for that. They're like, oh, that's too heavy for you. You can't get up into that high position. So let's cut the weight back a little bit. We really just need to not care about that and just go deep.
Just load it, yeah.
So that's sort of the marker that I'll put on that is really getting up to body weight on there, and then beyond. Now, how many runners can actually do that? Recreational runners, there's some work to be done for a number of them. So yeah, that's where we're sort of really pushing them in there to get to hit those marks.
Yeah, and now I'm just curious, with the runners that you coach, and you mentioned strength coaching, I think as well.
Yeah.
Do you often preemptively program this into your work with them?
Yeah. Yeah, it is. And I think even for the ones that are strong, like even for those that do have good calf strength, I'm putting that in their program as well. But it might be once a week versus twice. So, but no, for my runners, you betcha it's in there. It's the first exercise I'll put in there. And it usually is actually often the way I structure my strength sessions is usually having calf and plyos at the start. So whether that's an isometric calf exercise and then combine that with a plyo, or whether that's a weighted calf exercise and combine that with a plyo, then I'm putting that in their program for sure.
Throughout this process, you're doing bent leg and straight leg, is that correct?
Yeah, so again, it depends on there's this whole debate over bent knee versus straight knee. Traditionally, there was some that said, bent knee is soleus, straight leg is gastrocs. We know that in both positions, the soleus is equally as active, so the soleus is working equally as hard. With the knee bent, there's a little bit less gastrocs contribution. So I think it's nice to provide a bit of variety. There's some theories in terms of, Achilles tendinopathy, that there may be some sliding and gliding between the different fascicles there. So potentially, a mix of both positions. I think it's good to mix it up. I think, if you're doing it on one day, you're doing seated, and one day you're doing standing, or whether you're doing, 2 sets seated, 2 sets standing, whatever's going to logistically work a bit better for the runner. then I think it's nice to mix it up. You can sort of, if you've got someone with a gastrocs injury, you can bias that initially. Like if they're quite sore doing a straight leg and you know that, all right, well, let's offload that gastrocs a little bit. Let's go into a bent knee calf raise and we can load up that soleus and take a bit off that gastrocs. That can help too. The same thing goes to be said for different foot positions as well. So we know with different foot positions, even on slant boards and inclination angles, we can bias different calf components as well. So if we want to protect, a medial soleus injury, we might opt for a standing position with the toes pointing in. To bias more the lateral component there. And then as we go through rehab and we want to really then target that injury site, we go to toes turned out and target that through there. So there's things that we can do in terms of foot positions and slant angles as well to bias those components depending on the injury and where you want to go after.
Got it. So do you care about the degree of flexion that you put the patient in if you're trying to bias the soleus personally?
Yeah, knee flexion.
Yeah.
I find that if you're going to do like a standing bent knee calf raise, and again, you're loading it up sufficiently, the quad's going to fail before the calf is. Like, I have used those exercises before in the past, and that's probably one I'm not using so much anymore. I don't really do the knee bent. If I'm going to have them bent, I'll do it in a seated position. And so I'll just have them sitting down in a seated calf raise machine or in a Smith machine there and doing it that way. So, and that's the other one that you do see, like with a seated. Sometimes you see it on social media with someone seated there and they've got a dumbbell on their knee and they're just raising up and down. Now, that's a great exercise for someone that maybe has just ruptured their Achilles tendon and it's very early rehab for them. But everyone else, it's doing jack shit. It's so it's you might as well just be standing and doing it body weight. Then that's going to be doing more than what you are with a dumbbell on the knee. So yeah, that's sort of, I guess, one of the mistakes people make with a seated raise. And again, just not realizing how much you can actually take, how much load you really need to put up on there. Because again, for me, for instance, like if I'm doing a seated calf raise, like I can put out over 1.5 times my body weight on a seated calf raise. So I can put out over 100 kilos there. So for me to go through reps, I really need to put 80, 90 kilos on top of my knee. That's a lot of weight. And you might be able to do that again, having your partner sit on your knee and your kids and pile everyone up on top of your knee there and get going. But it's hard to do at home. That's where, again, getting to the gym and using the weights is probably the way to go.
Yep. And then how strict are you during this phase about like tempo of those exercises?
Yeah, so probably, again, encouraging sort of more slower repetitions. So that might be sort of, down 1, 2, 3, and then up. So I'm probably not super strict on that. Like I'm not saying to belt through the reps pretty quickly. And generally I find that the runners are pretty good at that, like that in terms of the self-selected tempo. So I'm usually not having to cue too much on that actually. But it's a good point. It's something that, you sort of look at, and if they're way off track, if they're going really quickly, it's like, no, let's slow that down. That's turning it more into a pulse than it is into a calf raise.
And I imagine once the load gets to a certain point, you kind of can't do that.
Correct. Yeah, exactly. Yeah. It's just we'll just burn it out. So yeah, absolutely.
All right. So we've walked through settle and load phase 1, phase 2, building strength. Phase 3, I imagine this is the one that people miss the most, which is restoring the spring.
Yep, exactly right. So that spring is, when we say, the calf and the Achilles together, they form a really important spring. That's what saves us a lot of energy when we're running, thanks to that Achilles tendon. That's why, the calf can take, 2 times your body weight when you're landing through there, is because all thanks to that spring. And, what happens when we run is the calf sort of functions quasi-isometrically. So it basically holds tight whilst the Achilles lengthens and shortens underneath it. So that's where, when we're talking about restoring the spring, we're talking about working on that, so that coordination of the calf and the Achilles. And we used to think, like, again, I was taught, a long time ago that plyometrics strengthen tendons, but they actually don't. We know now that heavy loading and isometric loading strengthens tendons. What plyometrics do is they help neuromuscular coordination. So they help the coordination of the muscle and the tendon there, mainly the muscle. So that's what we're doing this for. And this is often a step that's just skipped. They might do some bodyweight calf raises. They've rarely loaded up heavy enough, and then they just go straight into running. And so again, this is one of these intermediate steps that we need to be able to prove that we can handle this before we go into our running.
I'm thinking of now, like bone stress injury and getting a patient back through those kind of phases, it's very similar where it's like this phase often gets very like skipped first. It's you get them better walking and then you just jump to return to run.
Exactly.
So during this phase, what are some of the key like go-to exercises you're prescribing?
So, we spoke about it before about, just running them through those testing of seeing like how they go double leg, single leg, going into some pulses can be some good ways early on to introduce that. So just some fast calf raises on the spot there, and then working into pogos. Like I love pogo jumps. Pogos are probably my most commonly used plyometrics because they can be really useful for early phase, and they can be also useful for latter phase because as you get better at them, you start getting higher up off the ground, it's more impact through there. And so it's one of these exercises that can be naturally progressed. So I give these initially as a sub-maximal exercise. So it's more just, going for time. So whether that's 20 or 30 seconds, jumping on the spot there, doing those sub-maximal pogos. And then it's going into starting to attack those, like starting to get, high in the air, cueing the ankle movement, the ankle dorsiflexion, and really, really smacking that ground there. Nice quick ground contact times there is what we want to encourage even on the sub-maximal one. So it's nice and short on the ground. And then progressing that through our plyometric spectrum onto things like into then hopping in a line, hurdle hops, and then going into bounding. So that's often sort of like the plyometric that I'll work through during this phase. Now, we don't need to, like again, to be able to run, we're probably going a bit ahead of ourselves here, but to be able to run, we don't have to work through that whole spectrum. And that's probably where I've changed a little bit in it, that I've introduced running a little bit earlier on. So once I'm confident that we can handle a little bit through here, then I'll start the return to running process whilst we're still progressing the plyometrics through. So I'm not necessarily waiting until they've got to bounding before we start running. We can actually reintroduce that earlier. And that's something, again, I've probably changed on just even in the last few years, actually, in my approach on.
So it's almost like you're using the initial plyos as a way to assess their tolerance to that
Correct.
type of load.
Perfect. Yeah.
To then get them running more.
Yeah. Exactly right. Yeah.
And then backing up to the submaximal pogos. Am I right? You're using your hands, but for the listeners who can't see, it's almost like a light, how you would jump rope or something.
Exactly like that, yeah. So imagine you've got a skipping rope and you're just jumping really quick, nice and light on the ground. So
small amplitude, not leaving the ground a bunch,
No.
And then you're progressing that to almost this like very aggressive, like high amplitude, leave the ground, pull the toes up as you're in the air, hit the ground for EP.
Yeah, that's exactly right. And they're the ones that I'm giving for, my runners, well, if they've had a calf strain, towards the latter stage of rehab, or they're the ones that I'm giving my runners for performance, or, this is a maintenance, a really challenging exercise for you to do. So yeah, love a good pogo.
Yeah. And then during this phase, are there any objective tests that you're looking at?
Yeah, so this is when we can start to look at things like, by this phase I've already put them on to the force plates and I've tested their maximal strength. So usually my preference is for a seated isometric. Sometimes I'll do a standing, but that's more for more complex recurrent cases. I'll check both, but otherwise my go-to is usually a seated or half kneeling position. I do it in there. So I've got their maximal strength. We've even got them doing, ramping up and seeing have they got that rate of force development as well too. So can they get that force happening and get it happening really quickly? So I'm confident of that. And then then we can start to move on to some of our jump testing. So like starting with a counter movement jump, which is what we call more an explosive, testing their explosive ability. And then we can go on looking at their reactive strength ability, which is looking at repeated, so either like a repeated hop test, like a 10-5 hop test or a repeated hop, a drop hop test, or a single leg rebound test is another one that I use. But my preference for those hopping is more using a 10-5 over a drop or a repeated hop test over a drop hop. I just found a drop hop is, you've really got to cue it well. And a lot of runners aren't really, coordinated enough to do it properly. So it's getting them to hop on the spot explosively is certainly a lot easier.
Can you describe the 10-5 for us?
Yeah, so basically it's just getting them to hop on the spot. I'm lucky enough that I've got access to force plates again, so I'm doing this on the force plates there. But this can be done again with the Run Easy belt, and I have done that the same as well too. Using that is just getting them to hop on the spot as explosively, so they're trying to get in the air as high as they can, but also being quick on the ground. So hot coals on the ground, so really get off the ground quickly, but I want you going high in the air. And sometimes that might take a bit to cue them. Like sometimes they might be spending too long on the ground. So you really want to try and get that ground contact down. But I don't want it to be over cued. So I want to see again what they're naturally, what they naturally want to do and what strategy they're using. And that's where I'll test that now with that 10-5. So 10-5 is basically where they do 10 hops and then it calculates their best five performance in that.
If we look at like the Run Easy data, using Run Easy for this, what are you looking for in the data here?
So I'm looking for, first of all, looking at that ground contact time. So how long they're spending on the ground, or in the Run Easy, they use flight time. And then I'm also looking at the hop height, so how far they're actually hopping, because both are important. We want to see you could have equal. And so just for our listeners, what happens is that when you combine you get a reading called reactive strength index, and basically that's looking at combining flight time or ground contact time and the jump height, and so you get this reactive strength index. So you could have similar reactive strength index on either side and from person to person, but very different strategies. One person is spending longer on the ground and they're jumping higher in the air, and another person's the other way around. They're spending really quick on the ground, but they're not getting very high off. So I'm looking at the reactive strength index number, but I'm also looking at the different the numerator and the denominator of that to see, do we need to work on making them more explosive, or do we need to work on actually just getting more power and getting greater height? And that's also how we can then dictate the rehab for that particular person.
Nice, great. And then are you looking for symmetry there between limbs?
Generally. Generally. And we, for running, we should see pretty similar for those. Like I use the threshold of 10%. There's not a lot of good normative data on. In fact, there is no normative data on this test in endurance runners. So it's more sort of, I guess, experience what I've found and what I've worked on. So again, it is look around that sort of 10% asymmetry that we're looking for that. It's actually also, from all the tests that we're doing, it's probably one of the ones that's more correlated with performance. So, those that do better on the more reactive strength tests are generally the better performing runners. So you can have people that are very strong from a maximal strength, so they're putting out some really good numbers on the force plates on a maximal strength, but it's got a less correlation with running performance and running speed. So that's another interesting one from looking at it from a performance point of view.
Got it. All right. And then we are starting to look at the last phase, which is return to run. At what point do you look at the runner run?
Yeah. So that's where we're getting to this point now, really. So there's no point, obviously, getting the runner in there and saying, oh, yeah, you got a calf strain. Well, we're just going to get you on the treadmill today and really turn that grade 1 into a grade 3. No. So really what I'm looking for there, because to do a gait analysis, you're probably looking at having them running for at least probably up to 10 minutes. It might be less again if you're letting them get acclimatized to the treadmill. That might take sort of 4 or 5 minutes, and then by the time you do your analysis, and then there might be some things you might want to change. So you're looking at, they need to be able to run for 10 minutes. Okay. So we're not going to introduce that to them until they're at that point. And the early runs that we're doing in this return to run phase, the first run that we're often doing is 10 by 60 meters with either stationary or walk back recovery. So it's just really small runs, and it's like, well, that's hardly worth it. But as one runner said, he goes, took me longer to get dressed and changed than it did to do the run. So, and I'm like, yeah, that's true. So I have a shower afterwards. I'm like, yeah, you're probably not going to get a sweat doing 10 by 60 meters. So
no.
But that's where we're starting quite small. So yeah, when we get into, once we're sort of at that point where I'm like, yeah, we're pretty comfortable with doing that, then that's when we're going to put in our running gait assessment then.
Yeah. And are you looking at what are you looking for in their running assessment?
There's not a lot that's looked at calf strain and I guess, running technique characteristics. The most obvious one is looking at foot landing, right? So we know that, like looking at forefoot, rear foot, midfoot, we know that by landing with forefoot, it's placing more calf demand through there. And I've had a couple of really interesting cases where they had recurrent calf strains. So they come in with recurrent calf strains, and I put them up on the treadmill, and they were forefoot runners, and they were running right on their forefoot without a couple of them even without touching their heels down. And I'm like, is this your normal running gait? It's like, no, I've read somewhere or someone told me I need to be running on my forefoot. And so their calves were screaming at them because they were just running on their tiptoes for their entire run. So no wonder why they had recurrent calf issues. And you don't know these things, right? So I would assess running technique, more than what I ever have, but I would intervene less. So I'm looking at it, I'm checking, because you don't know if that person there that's been getting all these recurrent calf strains is running on their forefoot.
Mm-hmm.
So you don't know unless you look. So that's one I'm certainly you look on the lookout for. In terms of, look, Chris Bammer did some in his 2018 study. He found that those with recurrent calf strains, with calf strains, were more likely to show a hip adduction, a pelvic drop. So there was a greater pelvic drop seen. Now that was a cross-sectional study, so we can't say that that led to the injury, or that whether that was a result of the injury. We don't know. So I'm certainly looking for that anyway. And then in terms of cadence, it's an interesting one with cadence, because whilst cadence and manipulation around cadence can be quite useful for offloading knees and above, it doesn't actually do as much for the calf and the feet. And in fact, it actually can do the opposite if you're increasing someone too much and starting to transition them towards a more forefoot landing. That can actually increase the calf. So I think you're always going to be a bit wary with making sort of too big changes out of it. If the reason you're justifying it is to try and offload the calf. The big one is, that I'm looking for is that forefoot position, and then sort of, again, more that proximal control is something I'll assess. And that's one of the beauties of the Run Easy system, is looking at that dynamic instability as well. So I think that's a really, really important one that I'm looking for there. And probably the other thing is, increase in vertical oscillation as well. So that up and down movement, that might give me some hints that they're not very efficient at propelling themselves with that calf. So they're just sort of going up and down with that momentum. So they're probably a couple of the key running gait things I'm looking for there.
Are there any interventions you tend to do during this time? Like, as you're looking at their run, are you making any modifications?
Yeah, like if it's clinically justified, I'm changing it right then and there. And in fact, it's a good time to change it if we need to make some changes to their running technique, because we're building up their running. So we might as well get them working on that technique as we're building that up. So if it's justified and I'm working on it then and there, yeah, absolutely.
What do you think about like things like, all right, so we're entering the return to run phase, footwear, terrain, speed. Tell me about those things.
Yep. So you want to make it as easy as possible, flat, slow. We know that, again, once we start to increase the speed, the calf demands go up exponentially. We know that once we go running up hills, the calf increases as well. So no, we're not going out. The first run is not going to be, 8 rounds of 400 meters or a 5K time trial. We've got to earn the right to get that speed back. It's really easy. I don't say go too much easier. Like I've seen a few, I don't know if you've seen this too, calf strains where the runners have run with a friend who's much slower than them, and they've slowed right down, and then they've pinged their calf because they're just running at a way slower. And I think that's got to do with, and this is not something I've ever seen really documented in the research, but I suspect it's because, again, they're really slowing it down. They're increasing their ground contact time. The calf and Achilles is not really functioning very well. It's much like running on sand, really. You've got that increased time. There's just you're not getting that rebound, that slinging effect, that spring effect of the Achilles, and pop, there goes the calf. So I'm not telling them to run any slow. We're just getting them to run slow.
How about footwear? Is that something you try to modify?
Yeah,
or do you
so footwear's it is, and I'll talk about it all day with runners, but it is a really interesting one, right? Because we think about, so a couple of things, if we think about what's going to offload the calf, okay, so in that early period. So firstly, heel to toe drop, so looking at the pitch of the shoe, so obviously a greater heel to toe drop. So if we're looking at, something from an 8 to 12 millimeters is going to reduce some calf load there versus a 0 drop or a 4 mil drop. So that's one thing we're going to do. And maybe even, again, something you might do is put in some heel lifts, heel raises there. I don't generally do that for the first time calf, but if someone's having some recurrent calf issues, it's something I'll consider putting into their shoes, is having a heel lift there to potentially offload things a bit there. So that's the first thing. We know that also, features of shoes these days, like, a 4-foot rocker. So the rocket sole shoes, which pretty much most shoes have these days because they're getting so thick in terms of the midsole thickness. So they pretty much all have a rocker. So that's all pretty well and good. Stiffer, so things like carbon plated. Again, that can also help to reduce the demand on the calf and the Achilles. And that's, one theory as to why the super shoes work is by lessening the demand on the calf and the Achilles there. The caveat there that I'll put is, some people think, oh, great, so I'll wear my super shoes in my first run back. Where I'm like, well, I wouldn't go so far as that. Like if I don't trust the runner, because what's going to happen is they put that shoe on and all of a sudden, instead of running at, 5-minute Ks, they're doing 420s. They're off. Yeah. It's like, no. If you can keep it slow, then and you can be really strict on that, then yes, you can put it in there. But generally most of the time I'm putting people in their daily trainer and just telling them to get out there and keep it slow.
Got it.
Yeah.
Any other recommendations during this return to run phase?
Probably just in terms of balancing it all, right? So in terms of looking at, how you fit the calf loading in with the running and just making sure you're not doing too much.
Yeah, that's a great question. Is it same day? Do you run same day, non-consecutive? Like, what do you do?
Yeah,
how do you do
it? So again, we're looking at this runner, and I always hate using the word depends because no one likes hearing that. So I'll give you an answer, right? But it does depend, because it's like how much running do we need to get back to? How close we are to the event? All right, so I'll say that, but I'll give you an answer that people can actually use, because that always shits me when people say, "Oh, it depends." I'm not giving you an answer. So what we're going to do. Running is the priority, right? Running is where things are going to get injured most likely. And so what we need to do is we need to make sure that the carbs are fresher for that. Okay. So what I would prefer to do is to have our runner run in the morning, and then we're going to do our strength at some stage later in the afternoon. So that might be our heavy loading and our plyometrics there. We're going to do that later on in the day. Now, usually early on in the process, I'm often running a day off. So it's like we run one day and then we have a day off, and then we run the other day. And so we're just having a day in between. But then early on, we can do subsequent running days next to each other. And what we've just got to make sure is we're not fatiguing the calf too much, because if they've got quite low capacity, so we've tested them, they're not very good. And the other test we didn't mention before was actually a calf raise to endurance test, which is low tech, and you can do that. But if we're doing all that, our calf testing, and we're seeing that they're not great, we've got to be really careful about how much we smash them. If we're getting them doing weighted calf raises 3 times a week, they're running 4 times a week, and we're doing plyometrics on top of that, we can really cook them, and they can re-injure in that point as well. So really got to listen to the runner, and that sort of saying, it's like, oh, my calves are so sore, like I've got the worst DOMs. You know what? We're probably not going to run today. We're going to have an extra rest day. We might get on the bike instead, but we might have 2 days off in between. But that's where the timing of that becomes really important. That's where I'd rather, stack the days. It's what we call polarized training in that regard, where we make the hard days hard and the easy days easy. So that's what I'll sometimes put in there. Now, that's not to say you can never do your calf stuff on opposite days. I will often do that, and that's more for the runners that, again, timing wise, they can't get to the gym on that day. They can only do gym on the other day off. They've got fairly good capacity, so we don't need to, it shouldn't tip them over the edge there. And so sometimes I'll just go, run strength, and I might have a day off. So there's no hard and fast rules. I do put some examples in the guide as well too on how you might coordinate that as well, and how that fits in with the loading and the progressions of running as well too.
You bring up a good point about the just like hammering it with too much load when you're adding in running. You've been doing the rehab stuff. Is there a sweet spot for how often to do the heavy strength and the plyos?
Look, I think twice a week. From the research looking at strength gains and improvement there, I think that we know that, once can sometimes get you stronger, but it's more for maintenance. 2 gets you, stronger faster. 3 gets you a little bit quicker, but sometimes the juice isn't worth the squeeze there. So I'd say, the optimal is often around that 2 times. The easy stuff that we're doing early on, like with our body weight calf raises in that early phase and our isometrics, like they can be done every day because they're fairly low load. They're not that taxing. Stair climbs. Once I've start to get people into running, though, I'm usually dropping that easier stuff and just opting to go run, heavy strength, and then plyometrics will stay in there. And ideally, those that plyo and the heavy strength will always be in their program. And that's a mistake that runners make too, and clinicians is I'm good now. I'm just going to stop doing all that stuff. And they see it as rehab and this is again where I'll sort of educate the runners like, okay, this is rehab now, but this is actually performance enhancement too, right? This is going to help to keep you out of trouble. This will actually make you run better. There's studies showing, improving calf strength and help improve it, blah, blah, blah. So this stays with you. And that way you help to get buy-in for them to keep it in their week.
Love it. All right, Luke, I know it's getting late there. So I think
I'm still going. I'm high on energy and
you're ready to roll.
Pumping.
Yeah.
You got me talking carbs, so we could keep going for another 4 hours. But I'm sure our listeners would tune off before then. So
yeah. Well, so the one thing what I hear you say is, from the beginning of the conversation, is like pain is not the best guide for kind of guiding rehab here. The goal isn't just to get the patient out of pain, but it's to restore the full capacity, which is going to include strength and the spring. So those two things, making sure we don't miss that. And then being gradual and smart with that return to run. The exercises that you're prescribing early, like you just said, those are easier, they're lighter, so the frequency can be higher. As the intensity of that stuff goes up and we add run, we drop the frequency of that, we increase the intensity, we add the run. Is that a good kind of summary of what we've said?
Yep, that'll save about 80 minutes of listening. So if I just fast forward to the end here, then you're done. So thanks for summarizing my waffling on for 80 minutes.
No,
that's perfect.
The details are what's important here. And where can the listeners find this guide?
Yeah, so they can get it through my website, which is calf-Achilles.com.au. Otherwise, find me on social. So I'm at Sports Chiro Luke. I've got a link in my bio there that's got a link to the framework. I've also got sort of working on at the moment like a testing framework as well that will sort of go hand in hand with this as well.
Awesome.
That will have like some calf capacity testing, and then that's also part of I teach as well. I've got my own course, so that's part of the course as well. But I'll be putting that framework out sometime soon when I've got the time. I've got lots of things going on the go, but I will get that out. So keep an eye on socials for that. You'll see when that's released.
Awesome. Well, yeah, everyone definitely go find the calf rehab framework. It's awesome. Kind of guides you through everything we just talked about with pictures and everything to kind of help you. And then go follow Luke on socials. And what's your Instagram?
At Sports Chiro Luke. Sports Chiro.
Luke. That's right. Yep.
Yeah.
Awesome. All right, Luke. Well, I really appreciate it. I can see it's getting darker out there. The sun is like blasting me now. It's probably bedtime for you. It's time for more coffee for me.
Well, now you've kept me. I probably won't be able to get to sleep for a good 4 hours after this. So I'll need to listen to some quiet music and meditate or something, I think. But thanks very much, Jimmy. It's been an honor coming on. Thanks for inviting me.
Of course. Thank you.
Thanks, mate.
That's it for today on the Physio Insights podcast, presented by Run Easy. Would you like to share an interesting case, insight, or have a thought about the podcast? Comment below, and don't forget to follow us for more episodes.